Bismillahirrahmanirrahim. Moving forward to our next session, I am going to invite our next speaker, Dr. Junaid Muhib Khan. Dr. Junaid Muhib Khan is American board certified in pediatric medicine and neonatal medicine. He is currently working as the director of the medical education and senior consultant neonatology and associate director of our next session. I am going to invite our next speaker, Dr. Junaid Muhib Khan. Dr. Junaid Muhib Khan is American board certified. Okay, so he's a senior consultant neonatology and associate director of the residency program in SSMC and Mayo Clinical UAE. He is a fellow of American Academy of Pediatric and fellow of Royal College of Physicians Canada. He is an active member of Committee of Neonatal Institution Program, and he has vast experience in medical education, and he is visiting faculty in Pakistan and Canada as well. So he has presented many national as well as international conferences as a speaker. So over to you, sir. Sir, can you hear?
Yeah, I can hear you. You can hear me?
Yes, sir.
And you can see my slides, huh?
Yes, sir. Welcome.
Okay. So I will start now. And thank you very much for giving me a chance. So it's a very vast topic. So I might take a little bit of a time because 2-3 modalities hai, I have to touch base on that. And then I will give you some scenario that in which of that scenarios. Yeah, hello. You can hear me. Hello, you can hear me. Somebody talking on the phone. I think. Faraz, if somebody is talking on the phone. Can somebody tell me that you can hear me?
Yes, sir, we can hear you. You can continue, please.
Okay.
Yes, you are audible.
Okay. So I have nothing to disclose, but I have to say that I have some research grant from some of the CPAP modality, which I am going to talk, but other than that, there is no financial conflict of interest. Acute lung injury, this is the New England Journal of Medicine 2000 publication, like 22 years old, but this is in adult. And as you can see, the acute lung injury is not the same in all the zones of the lungs. So here is the picture of a CT scan, and you can see there's a severely diseased region. And as you can see, this is the open lung and it is healthy lung, and it is in between. So there are 3 types of injuries or 2 types of injuries in one lung. So how the hell we know that which pressure is required? Because if you give too much pressure to this lung, you can injure this lung. But if you give too less pressure here, this is not beneficial because this is very severely this thing. And this happened in the COVID, that we don't know, and that many patients who went to the intubation and ventilation, they died because of this. So we can produce more injurious if we ventilate those kids. So the mechanism of damage is not to the immature, but any lung. It is the same as we discussed in the morning, that excessive tidal volume PIP, PEEP, prolonged inspiratory time, PEEP, gas trapping, insufficient FRC, infection, inflammation, oxygen toxicity, you go ahead and continue for a lot of causes that. But what I am telling you in the morning, that effect of lung volume on the pulmonary vascular resistance. So we have to deal with that. Now you can see, if you give too much lung volume, This is the overexpansion, and the alveoli is overexpanded, and the vessels is become constricted because of this what you call expansion of the alveoli, which is increase the pulmonary vascular resistance. Similarly, if you give the atelectasis, if you collapse this one, then the vessels have also collapsed because there is nothing to have a gas exchange. So again, the pulmonary vascular resistance will increase. So you have to give the ventilation, either non-invasive or invasive, with the functional residual capacity, which is the normal. At that level, the PVR is the lowest. So that's why in the persistent pulmonary hypertension, it is very, very difficult to oxygenate the baby. Okay. Now, Azim discussed this pressure volume loop. This is the pressure volume loop, which is the physiological one. Okay. But no one is breathing like that. Try to breathe like that, that the maximum you can go up, and it is the over distension, and then exhale whatever you have, which is atelectasis. Now, if you do these type of breathing 5 to 6 times, try to do it now. Take it, the deep breath, and then exhale everything. After 5 to 6 breath, you become very, very tired. So we have to ventilate, or we have to do our ventilation strategy in the safe window that me and you is breathing right now. And this is the concept of the high frequency also. So let's say the nomenclature, or the what modalities we have in non-invasive ventilatory support. So first is the nasal cannula. Nasal cannula can be the low flow nasal cannula and the high flow nasal cannula, as you can see here. Then we have a CPAP, which is the gold standard of the non-invasive ventilation. It has the constant flow and the variable flow. Constant flow, which we are using, most of us, it is bubble CPAP and conventional. Variable flow is very few devices like infant flow drive or the jet ventilator, which has the interrupted wall, you can produce it. There are some studies that some is better for the carbon dioxide removal. The variable flow is better, but most of us using constant flow, but it is the same whatever you have it. The third modality which I want to touch base is the NIPPV. It can be synchronized and non-synchronized. The most of our ventilators give the non-synchronized IPPV, non-invasive. The fourth one is the BiPAP. I just will give you the one slide because this is again the misconception that the BiPAP is the same as NIPPV. No, this is not the same. Okay. And the nasal high frequency ventilation will give you in the end 2-3 slides. There's a sixth modality also, which I use a lot, but it is going to be with one of the ventilator only. I wrote an article on that. This is another conflict of interest, which I have to tell you that this is can be delivered by the Mackay ventilator only. So this is called the non-invasive ventilation by the Nava. Nava means neurally adjusted ventilatory assist. It means that there's a catheter you pass, it get the signals from the diaphragm, and then give the breath accordingly. So it is a very synchronized way to give the ventilation and very less damaging, but it has a lot of research going on that, but it is one of the another way to provide the non-invasive ventilation. So start with the normal, which is the CPAP, that how we can, which is the most common one and the gold standard right now. Before we go to that, again, the basic, you have to know that Azim already tell you about functional residual capacity, compliance, resistance, pulmonary dynamics. Look at the resistance, the normal resistance in a newborn, full term is 25 to 30, but if you intubate, the resistance go up to 50 to 150 centimeter of water. So that's how you are very damaging to the lung. Then, of course, you have to know the time constant. Time constant is the resistance time compliance, okay? And one time constant is about 67% equilibrium. So the time constant expiratory is more than the inspiratory. And why it is important, we'll go through when we will go some modalities. Another thing which I want you all to remember, the respiratory reflexes, especially the first two ones, the Herringbird reflexes and the Hertz paradoxical reflex. These are the reflexes built in, these are the protective reflexes, we all have it. And I know this is many of you don't remember that, but it is very important to know. The Herringbear reflex is a protective reflex, and you can demonstrate in yourself now. Try to breathe, 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 breathe. And at one point you have to exhale. So this is called the Herringbear reflex. Herring and Brewer are the two scientists who discovered this reflex. So this is the lung inflation inhibition of breathing, which we don't have the actually during the ventilation, because you just set up pressure. At that point, maybe the baby don't want that pressure. So this is the problem. So this is a very protective reflex we have. The head paradoxical reflex, head is again the name of scientists, and the paradoxical means the paradoxical to the inhibitory reflex, that the rapid inflation. So it's called the diaphragmatic contraction. So for example, when you tired and then you try to do like this as a deep breath, this is called the head paradoxical reflex, because the body senses that you have, a little bit of hypoxia, and you have to take a deep breath, which we call the sigh breath. Intercostal phrenic inhibitory reflex, the chest wall distortion or the shallow inspiratory efforts, and the upper airway reflexes, we should all know, like a nasal irritation, suction, apnea, liquid and larynx, and so on and so forth. The first two are very important to understand the non-invasive ventilation. So these are the three forms just published in one of the article 2021. You have to understand that these are the few interfaces what we are using to the interfaces, the equipment through which you are providing the support. So most simple one is high flow nasal cannula. It has one limb, inspiratory limbs, and go into the nose. It is the humidified and heater, so that's why it's called HHNFC. You have to have a blender, as we discussed in the morning, to blend the oxygen with air. Otherwise, you will end up giving very high concentration of oxygen, and you don't know how much oxygen you are providing that baby. So that's why when the people ask me that what should we buy blenders. Okay, blenders is very important. Okay, you are thinking of buying the ventilators and all those, but I think the most important thing is to buy blenders. The next is the bubble CPAP. Is very easy, and we demonstrated many times how to build it up. It is commercially is also available. Again, this is the air and oxygen, the blender, heater, humidifier, inspiratory, expiratory limb, and there is an interface which is going through it. So the expiratory limb is going into the bubble chamber, which is developing the pressure, and with this what you call a stick, or what the rod, you can measure it at 5, 6, 7, 8, or whatever the pressure. It is a very simple device. You can have it in your unit, and very, very effective device. The next is the NIPPV. The NIPPV is, you have to have a ventilator for that, and then again air and oxygen go through the ventilator. And then inspiratory, expiratory limb, and this thing. So for that, you have to have a ventilator, and for high frequency oscillatory ventilator, non-invasive, or the Medin, or some other equipment for that. So these are the three main interfaces or the three main ways which we can provide the non-invasive ventilation.
Dr. Junaid, can I interrupt?
Sure.
What about the Fabian ventilator? So Fabian way of giving the CPAP?
Yeah, the Fabian is the same as that you can go through the, you just put any ventilator, you can provide the CPAP. You just put the PEEP and that's about it, and monitor the oxygen, and that's it. But it is not that effective as compared to the bubble CPAP. But anyway, this is the any ventilator you can provide only the CPAP also. You just have to put the PEEP and your FiO2. That's it. So the Fabian or the Draeger or any other ventilator, you can provide the CPAP.
Yeah, thank you. Thank you.
Yeah. Now, how the mechanism of the nasal CPAP first. Of course, as we can, I don't know this, that it reduce the airway resistance. So that's why it is very important what Azim told us in the morning. If we don't know what is the resistance, then how we know that it is how established. So it reduces the upper airway resistance because the upper airway is the dead space. Okay, there is no gas exchange going on. And on top of that, if there is a resistance there, then you can imagine that we cannot have a good lung inflation and the gas exchange. So the NCPAP is reduces the upper airway resistance. Again, the functional residual capacity, I told you, Azim told you that what is the functional residual capacity? It has to establish that. If you don't establish the FRC, then you cannot give the good ventilation, whether invasively or non-invasively. It decreases the chest wall distortion, which I told you about the the reflexes, augment the spontaneous breathing efforts. This is another thing that what the Herringbear Reflex told, that of course you take the breath, and then the paradoxical head reflex told that you need to breathe sometime a little bit on a higher pressure. It decreased the need for and duration of IMV, and I will show you some evidence on that. So look at on these graphs. Okay, this is very important to understand that this is the end expiratory lung volume. Okay, and this is the pressure or the PEEP you are giving. So if you increase the PEEP, you increase the end expiratory lung volume. Okay, which our requirement is. Not only that, it decreases more the CPAP, it decreases the pulmonary resistance, as I just mentioned to you. And it's a very old slide from your Guyton. We all forget Guyton. Guyton is the best book I can imagine. So this is the supraglottic resistance and the CPAP, and as you can see that the resistance is going to decrease with your increasing the PEEP. We talk about the compliance delta V divided by delta P, which increase the compliance. So more the PEEP you give, you increase the compliance, and then of course good ventilation, and then decrease the PCO2. So these are all documented, proven effect of nasal CPAP. In some are animal studies, not some, most of them are the animal studies. This is a controversial thing, but I don't want to confuse it, but you have to remember that. So for example, if a baby delivered in front of you and the baby is apneic, the first thing you will start the bag and mask ventilation. Okay, you cannot start the CPAP on the apneic baby. Remember that. But let's say the baby is well established in your NICU and have some apnea. So there are some effect of the CPAP, especially if you have the obstructive or the mixed apnea. Of course, there is no effect of CPAP if it is a central apnea. I just want to show you, this is a very old slide again from the textbook of physiology, but I want to give you impression that do not in a hurry to ventilate that kid. Okay, this kid might be better if you increase the pressure and increase the PEEP in those babies. So please just remember all these little things so you can understand better. Our aim is to avoid ventilation as, the invasive ventilation as much as possible. Now, how the bubble CPAP generate pressure oscillation is the same as like a oscillator. So this is the ventilator CPAP, which gives you the pressures. You set pressures, whatever it is, 6, 7, 8, whatever, and it gives the ventilator. But in the bubble CPAP, it gives like a oscillation thing because of the bubbling of that in the bottle. So this gives you a similar effect of the high frequency ventilation, and it is a little bit better than that. Now, if you see that, what is the meaning of that? It is the experiment long time done in rabbit lung, if you can see. So look, if somebody breathing like this, then that the dilatation, which is maybe the over ventilated, and then the sorry about that, and then the collapse, and then again, it will be more injurious to the lung. Instead of that, which is the concept of the high frequency and the bubble CPAP, that just give a descending pressure and then just give an oscillatory effect for the gas exchange. So this is the concept of the bubble CPAP. The problem with the bubble CPAP or any form of the CPAP is the pressure control when the mouth open and when the mouth close. So look at this, the two pressures, the pharyngeal pressures and the CPAP pressure itself. If you close the mouth, the pressure goes up. If you open the mouth, the pressure goes down. It is no rocket science. That's why sometimes in a very small baby, they put a band, but do not put a very tight band because it can cause pneumothorax. It will increase the pressure too much. So if the baby is doing fine on the CPAP, no need for that tie or the band around the face. But if not doing very well, then you can put to increase the pressure which we are providing. This is another way to see the pressures. So in preterm infant, the clinical effect, as we all is starting CPAP, you should start in the DR. And only in the case if it is failure, we will talk about it, then we will do. The secondary CPAP is starting after the extubation or started on depending on the indication. Now, I don't want to go to the evidence. This is very well evidence, very well studied, but just to see all the major trials, which is the Stephen Dunn, Colin Molly trial, Sandry trial, support trial, all is in the favors of nasal CPAP versus intubation death or BPD is the outcome. NCPAP for the stabilization, again, there's a lot of evidence about that. I don't want to go through it. It's also very well established. So how you are giving the CPAP? Either you are giving by the infant flow drive, by the bubble CPAP, or by this machine. Somebody have it, but the most simplest and the cheapest form is this one. This is one of the interfaces which the Fisher-Paykel has. This is the study, and two of our the AKU involved in that, Dr. Bhutta, as you can see the name here, and the Harish Kriplani. Dr. Harish Kriplani is a very good friend of mine, is now in the US. He's retired. He did a lot of research on different topics. So what they said, that non-invasive respiratory support for infant and low and middle income countries, bubble CPAP compared to mechanical generated CPAP reduces the need for subsequent invasive ventilation. That's the thing when Dr. Shabina asked me about the question about the ventilator and this thing. So the bubble CPAP is the cheaper setup, and it is effective as according to this publication, which is published in 2016. I think Dr. Asma is also at that time in AKU. Eric is another good friend of mine who is the first author of that. So these are the different prongs which we are using. This is the Fisher-Paykel prongs. This is the Hudson prongs. We are more biased toward Hudson prong because I trained in New York and we did under Dr. Wong and Dr. Richard Colin. So we use, but this is the Ram cannula is also now a very famous one. So I think if you have a Ram cannula, Hudson prong, these are the best way easiest to, and the very less nasal trauma. You can use the CPAP mask or the Fisher-Paykel interface also. It depends what is the easiest available you have it. So studies on nasal CPAP interfaces are limited and many studies are biased. Okay, so for example, if you take the Columbia Presbyterian, they are more in favor of Hudson prong. If you take the Dr. Ramanathan, because he invented the Ram cannula, he's in favor of Ram cannula. So whatever is available to you, I think it is much better as compared to the any one you will try to get it, or this whatever available is, you try to practice on it, and then you can be better off. Now there's the article in the May 2020. There's a lot of things, a lot of settings you can put it, but this is the hello.
Dr. Junaid, sorry for interruption. And there is a question, can we ask in between?
Yeah, you can ask. You can interrupt me anytime. Yeah, tell me.
So, Dr. Junaid, this question is on Ram cannula. Just wanted to know your experience plus evidence regarding how good is a Ram cannula for delivery of CPAP, because there are some school of thoughts which would not recommend nasal Ram cannula as a source of CPAP delivery. So any evidence on that? WHO does not agree to the Ram cannula with nasal CPAP. So can you throw some light on that?
Yeah, so that's a good question. But the thing is that if you do the practically, that's why I am saying it, that we are very much meticulous about when we put the baby on CPAP, and you know, so the thing that how your staff is trained and how your nurses is trained. The Ram cannula anyway now is FDA approved also. So Ram cannula can give high flow nasal cannula, NIPPV, and the CPAP also. So it is as equally good as it is like other interface. Of course, I prefer the Hudson prongs here, but the problem is that it is not available in all places. This is the two binasal, and it is also very cheap setup. But if you ask me my experience, I have the evidence, but those evidences are from the Professor Ramanathan, who is the inventor of this thing. But he did a comparative studies. If you want, I can send it to Vikram, and then you can look into it. The OptiFlow is the thing which is using the Ram cannula for high flow nasal cannula, and also for the CPAP. But we use also Ram cannula for NIPPV, and it works actually. So I think it depends that how comfortable you are using that interface. That's why I told you there is no such comparative, and there are very limited studies. So the short binasal compared with single prongs, this is the main thing you have to understand, that the binasal compound like this, okay, or like this, is much better than the single prong. So we never use single prong, and mask compared with short binasal prong reduce primary secondary CPAP failure in some of these studies. So you can use the mask or this thing. So I think most of us is using either this one or Ram cannula for providing the CPAP. I hope I answered your question. So if you come to the settings, this is a different settings, and you can have a lot of literature on that. But these are the initial settings for the CPAP, which is 5 to 6 centimeter maximum. You can go to 8 to 10 Beaning parameters. Then the lowest setting is the 4 centimeter of water. But this is the very generalized thing. It depends what you want to achieve on that. But the main thing is that have a very high threshold for intubate the baby. So what is the optimal level of the CPAP delivered non-invasively? We are still looking into that. There are many studies. This is 2017, but we don't have a lot of evidence on that. They took 20 preterm infant less than 32, had CPAP increase from 5 to 10 every 20 minutes, and then decrease in step to baseline CPAP, which is 5. So regional lung volumes are assessed, increasing CPAP reverse atelectasis, no effect on hemodynamics, no effect on PCO2, no single and standing pressure. But again, this is done by the Dr. Peter Davis. You all know this from Australia, very nice, humble person. And this is, but the problem with this study is a very, very small study. So the optimal CPAP level, we cannot do it, but at least the 5 centimeter. The reason for the 5 is not a magic number, because the healthy lung require, especially in the neonates and the premature, is almost 3 of PEEP. So if you have a diseased lung and you have to support it, so at least you should start with 5. And you can go up to 6 to 8. Try not to go above 8, because as per Dr. Colin Morley's study, the chances of having the pneumothorax is high. Okay, so please have these things in your mind when you are putting the baby on CPAP. So this is the future trial going on. They called the optimal trial, that they want to know what is the optimal CPAP, especially in a very small babies. So 26 plus 0, it means 26 weeks to up to 30 weeks. 29 plus 6 is approximately 20. And the higher group is the higher group is 6 to 8 centimeter. If the baby is on 30% oxygen, then 8 centimeter. If it is 21 to 22 to 30, then 7, and then 6. Here is the lower one in comparison, which is 30 is 5, 22 is 4, and the 21 is the 3 centimeter, which is the normal PEEP level. And then they want to compare. So they started in, I think, 2020, 2022. It will take 2 to 3 years, and then we will get an answer. So for the current situation, start with 5, do not start less than 5. Then the question arises, weaning from the CPAP, when to wean. There's again different things, but it's depend on you. The recommendation is if less than 7 days old, then you have to have FiO2 to 21%, no distress, no significant apnea and bradycardia. If more than 7 days old, then it depends on your discretion. But the problem is that when the baby is small, okay, so what is the criteria for that? Let's say the eligibility criteria according to this, which is presented in JAMA, that, sorry about that, it's 29 weeks or greater nasal CPAP with the pressure less than 8, oxygen requirement less than 30, respiratory rate is less than 70 per minute, and less than 3 episodes of bradycardia. It means less than 70 or desaturation in the preceding 24 hours, then you start decreasing it. How to wean it? There are 3 methods, okay? M1, M2, M3. The M1 is just taken off the CPAP. M2, the cycle on and off CPAP with incremental time off. Okay, so for example, 1 hour off, then the next time 2 hours off, then 3 hours. The M3 is with the M2, like cycled on and off CPAP, but during off period, you support it with the nasal cannula. And then they see what is the result. So you can see the M1 is the basic one, and we are also doing it in the same, that we just remove if we think the baby is established breathing and there is no need, so we remove the CPAP, because time of wean, total days of CPAP, oxygen duration, BPT, length of admission, and as you can see, all goes in favor of M1 as compared to M2 and M3 method, and all are statistically significant. So if you think the baby is ready, just remove from the CPAP. Don't do this cycle off and cycle, and don't put on flow. So what we are doing, If the baby, let's say 27, 26, 25 week are born, we continue with the CPAP unless and until baby reach 31, 32 weeks post-menstrual age. It has to be more than 30. No supplemental oxygen requirement for last 48 hours. Asymptomatic PDA, less than 3 self-limiting bradycardia or desaturation. I give you the numbers: 70% desaturation, 70 bradycardia in the last 24 hours. More than 90% saturation on 21% CPAP. Now,
Sorry, another question.
sure,
Do you follow the histogram also for weaning from CPAP?
yes, we follow the histogram also for the CPAP, this thing, and in a very small babies, we are utilizing the NIRS also, but I don't want to take because we are,
Yeah.
talking to the Pakistan,
Yeah.
so that's why I didn't mention it.
Sure.
But one thing I want to mention it, if you remember in our academic neonatology group, one of our colleagues said that it is very difficult to keep the saturation 90% on 21% CPAP because of some, and he or she told that it is 70 to 80% time more than 90%. This is not correct. Okay, I mean, not correct means that if the baby is not maintaining more than 90% or 90% saturation on 21%, then the baby is not ready. If it is problem with your pulse ox, then check it with pulse ox. Of course, you have to consider the artifact. If you have to consider the what you called the movement of the babies, because pulse ox is a very crude method for just to notice this thing, but at least 90% of the time the saturation should be more than 90%, and of course the baby has to free of the infection. So this is the some things that we've been of the CPAP, but you can decide according to your babies also. So discontinued nasal continuous. Yes, go ahead.
Sorry. A question, Dr. Junaid. So do we know that, I know a trial is going on the extent of CPAP pressures that can be used, but do we know, because I remember when we started CPAP almost 1.5 decades back, we used to start with high PEEPs, as high as 9, 10, and then wean it down to 6 and 5. So are there any studies, because here I'm saying it for the audience, I'm speaking here for most of these our residents, our trainees are reluctant to start on us. So would you please give them a reassurance or evidence that what is the pressure, and are there any, like you said, start with 5 minimum and max 8 to be in the safety range. But are there any studies which show that starting with this pressure leads to reduction on the number of days on CPAP versus starting off on a lower pressure, which would increase the duration of the CPAP? So something on that, Dr. Junaid, would be helpful for the audience.
Sure. So the initial setting I told you is the minimum is 5. You can start with 6 also if the baby is small. Okay, but maximum you can go 8 to 10. 8 and above is a very dangerous thing. So be careful about that. So the minimum is 5 and the maximum to us is 8. We will not go more than 8 and 9. The reason is for that the chances in the Professor Colin Morley study that having the pneumothorax is very high, which we call the Coin trial. If you read that trial, the only thing is that the pneumothorax is very high in that trial. All other trials, support trials, the support 1 and 2 and the Vaughan Oxford, all these trials start with 5 and 6 initial settings. So be assured that the CPAP setting of 5, 6 is quite good enough to give you a PEEP, which is to maintain your functional residual capacity. It's a very rare than when you need a little bit higher PEEP in very minimum settings. This is my answer to that, and this is the study. What they are look at that even in this, which is the higher PEEP range here, they are using the FiO2 30% and then only using the 8 centimeter, and the rest is the low. And here you can see in the lower group, the 5 centimeter and the 30% FiO2. So do not jump into the very high PEEP, okay? And then it is give you a quite beneficial effect if you started with 5 to 6. I hope I answered the question. So, okay. So discontinuation of nasal CPAP, pressure mean to 3 centimeter did not decrease the duration of CPAP. So you shouldn't wait that you should wean the CPAP up to 3. No, if the CPAP at 5, okay, that's fine. And all other parameters which I mentioned here is is there, then it is fine. Then you can wean off the CPAP. So there is no difference if you put the baby on 3 or 5 with other parameters ready to wean. So again, this is the algorithm you can modify according to your need. Okay, I'm talking about very small babies. Okay, but if you have that many small babies, then be careful, because in the next part of my talk, I will talk about NIPPV, which is, but this is our failure criteria. As you can see, the oxygen is more than 40%, carbon dioxide is more than 60, and PEEP is more than 6. Then we give the miss, try to put back on the CPAP. Of course, if the baby is on cardiovascular compromise, frequent apneas, then we intubate and keep them intubated, give the surfactant, and then try to wean the ventilator as soon as possible. If it is oxygen less than 40, carbon dioxide less than 60, and PEEP is 5, we continue with the CPAP with close monitoring. And if the baby is fine and oxygen come to 21%, then we try to wean it off, until the baby reach 30, 31, 32 week of gestation. Remember, the PEEP or the CPAP is not only helping in oxygenation and ventilation, but it helps in developing the lungs also. So that's why we are saying that keep the baby on CPAP until 30, 31, or 32 weeks of gestation. So CPAP improves the lung function. CPAP reduce the death or BPD. Secondary CPAP reduce extubation. Ventilator CPAP and bubble CPAP might have, the variable flow CPAP and bubble CPAP might have some benefit over the ventilator CPAP. Binasal is superior to single prongs. We never use the single prongs. So try to use whether the Hudson prong, the what you call the ram cannula, or the mask, or the Fisher-Paykel prongs. Is up to you, but you have to understand the interface. Okay, so this is the Dr. Wong's. Dr. Wong's is the, is the guru of the CPAP, and especially the bubble CPAP. And this is the pulse of wisdom from him. It's a very old, when I was doing my residency, he told us this thing. At Columbia Presbyterian, where he's working, CPAP is almost a religious attitude. Columbia nurses make CPAP work in infant that would be intubated in other units. The experience of the nurses make all the difference. Doctor play a very little role in CPAP. So that's, I told him, saying that this is the teamwork, especially the nurses should know. In Lahore in 2014-15, they published a little bit of booklet of mine, how to put the CPAP and how to do that. I think Kumar Vikram has that booklet, and it helped the nurses to maintain the CPAP. So please train your nurses, and because without your nurses' support, it's very difficult to have CPAP. So the CPAP is the gold standard. Okay, so I know, but there are a lot of things, but I want to continue. Vikram, can I continue? Or if somebody has some other questions.
I think no question, we can continue.
Okay, so now there is another modality, high flow nasal cannula. How the high flow nasal cannula fit into the spectrum of non-invasive ventilation. Use of high flow nasal cannula is increasing. 2/3 of the US academic unit, 2/3 of the Australia, more than 80% in the UK, and they are using it. So, but this is the just published by Sand et al. This is the Italian author. It's just like last month or a month ago in 2022. Look at that significant increase in NIV support, especially in the UK. CPAP use increased from 21 to 28, while high flow increased from 1 to 7%. But the problem is that high flow nasal cannula use was associated with increased odds of the BPD. So there's a problem with the still as a primary support in a smaller babies. So I will give you some evidence and I will tell you in which babies you can use the high flow nasal cannula. So why is the high flow easy to use, less CPAP, less nasal trauma, no pneumothoraxis? Not true, no pneumothoraxis, but very, very few, decreased work of breathing. Nurses love it. Babies are more settled. Parents are more happy. If you see the nursing perception, most of them are very much, comfort with the nasal CPAP. Which mode of post-extubation they want a nasal CPAP in a smaller babies, but the high flow nasal cannula in a bigger baby. And we will try to solve this mystery that why they need it like that. Parental, if you see the parental assessment, child satisfied, contact interaction, possibility to take part in care is also easy in the high flow nasal cannula as compared to the CPAP. Again, there are a lot of ways you can provide the high flow nasal cannula. The most easy and the cheapest way is the OptiFlow. We are using the RAM cannula. Again, there are the different sizes. There's one machine called Vapothumb. There is no advantage to throw the money on that, but people are saying that is more accurate pressure, but I mean, it is all the company-based studies. So OptiFlow is much easier. You just need a blender here and also the humidifier. That's it. So these are the systems: flow generator, blender, heating cannula, and the prongs, and pressure relief systems. You should have it. Okay. So these are the different ways. This is the Madden machine. You can provide it. If you don't have it, you don't use it. This is the easiest way to provide. Just have a blender, put a source from it, heat it and humidify it, and give it to the baby. That's it. What is the difference between CPAP and the high flow? The delivery devices may be the same. Some are same, some are different. Gas resources are the same. The gas flow is 6 to 10 liter per minute. The high flow is not recommended to go more than 8 liter per minute. Interfaces are the same or maybe the different. Interface dimension is fill and block the nares. Here, you maximum 50% of the diameters of the nares. And needs for chin straps is often if it is a very small and sick baby as compared to the high flow. How it works? So high flow is wash out the nasopharyngeal dead space. So increase the flow, you increase the pressure to overcome the dead space. You all know from the morning talk what is the dead space, where there is no gas exchange. It creates the positive pharyngeal pressure, the same as CPAP, which I just showed you in a CPAP part of this talk. Increase FiO2 and reduce carbon dioxide rebreathing. So look at this, that if you give the, this is the airway pressure, and this is the low flow, and this is the high flow. So increase the flow, you increase somehow the airway pressure. It reduced the inspiratory resistance, same again as we told in the CPAP, is the provision of positive airway pressure, reduce the obstructive apnea, and stent small airways. So similar way, it is the fluoroscopic diagrammatic view that you end expiration, then start inspiration, and then the peak inspiration, you are fully dilated. So this is the way the high flow is working in babies. Higher the pressure, higher the flow, higher the pressure. This is not a rocket science, but this is also proven that this is a very linear correlation between those two. Physiological mechanism responsible for the beneficial effects. So as I told you, these are the effects of high flow, these are the effect of heated gas and effect of controlled FiO2, and these are the same which I just told. This is just published in 2021 in Journal of Pediatrics. So what are the settings? Again, we have a different settings for the different age groups, okay? So infant children, I add the children also because there are many pediatricians sitting, but anyway, this is the thing, we have a different, I will show you one table in a minute. So this is the table, this is the neonate up to 1 month, infant, preschool and school. So we are talking about neonates. So this is the very good and extensive studies published in 2015. It not only gives the what setting you have, then what is your first escalation therapy, what is your second escalation. If this fails, then you go to this. If this fails, then it's go to you this. So this is a real time study. That means that it is based very on clinical scenarios. So anyway, this is the thing, 6 liters per minute, and FiO2 40% is up to you that how the baby and how big is the baby. Now, Cochrane review, come to the evidences. The Cochrane reviews in 2011 has had insufficient evidence to establish the safety, but later on there was a lot of trials. 2012, again, Dr. Collins trial, and then Dr. Yoder trial. It helps that high flow is really working. Okay, somebody want to admit. Okay, anyway. So then there is in 2014, I'm going in a chronological order, but these are the main trials which compare with the CPAP. So the high flow for the post-extubation care, and this find it out, this is the non-inferiority trial, that it is inferior to CPAP or not, and it shows that it is not inferior to the CPAP post-extubation. Again, it is published in New England Journal. It's a multi-center randomized non-inferiority trial. Dr. Peter is involved in it. If you see the high flow nasal cannula, nasal CPAP, primary outcome is failure of the assigned treatment within 7 days. Risk difference is 8% only. So it is, they mention about the 10%. Less than 26 weeks also, there's about 20%. So it means it is inconclusive, but not inferior. So post-extubation, this really work. And then if you go more than 26 weeks, then the risk difference is only 5%, which is again not inferior to the CPAP. Reintubation within 7 days, again, the risk difference is only 7%. So which is again is not inferior to the CPAP. So there is a secondary outcome, there is no difference, but of course, the nasal trauma is high in CPAP as compared to high flow. This is well known, and the pain score is higher in the CPAP group as compared to the high flow nasal cannula. So the assessment of the pain, they do it by PIPP score, which is the infant pain profile score. It shows that the CPAP has a duration of cry is 49 seconds as compared to high flow for 22 seconds. So this is, and the more than 12 score in 13.5% as compared to the high flow nasal cannula. So the conclusion for the post-extubation support in a very preterm infant is it is not inferior. But what happened as a primary care, and then is the HISTER trial, again, the same group, the Australian group, Peter Davis and his friends, that they found it out that this failure within 72 hours is much higher in the high flow, and it is more than 10%, so it is inferior to the CPAP group. Same with the intubation is higher, that with the confidence interval is not that much difference within 72 hours of randomization. So the risk difference for intubation with high flow is 3.9%. Secondary outcomes is almost the same. There is no difference. The nasal trauma, of course, is more in the CPAP group. The cost is almost the same in the US hospital, $29,000 versus $32,000, which is not big a difference. So the high flow therapy results in significant heart rate of treatment failure. And this is the latest after all those combined. The hipster trial showed in 2017 that it favors the CPAP. Then again in 2018 from the India, again showing the same results, but this is the small study, 139 and 133 infants in each. This is the latest one, which is the again 2022, the same article which I mentioned a couple of months ago published, and it is shows the CPAP treatment is higher as a primary support to the smaller babies. This is just I want to put for the bronchiolitis of the pediatrician setting that which level they can start on what blood gases and how to escalate it. Just take this my talk. I will send it to the Vikram and then you can have it. There's no time to go through all this, but it's a very comprehensive treatment for those who are bigger babies, let's say those 1 month, 2 month old bronchiolitis with RSV infection. So these are the efficacy of this thing. These are a lot of research on it, and it is pretty much effective. Now the summary. So this is, you have to remember, use of high flow nasal cannula in post extubation more than 28 weeks. Yes, okay. If you extubate the baby, you can put him on high flow nasal cannula if the baby is stable. In less than 28 weeks, you can do, but you have to monitor the baby very frequently and can be done with a great caution. As a primary therapy in the less than 28 weeks, no, the CPAP is the gold standard. You have to put the baby on the CPAP. Use of high flow nasal cannula as a primary therapy more than 28 weeks can be, but again, with a great caution. Okay, so the mostly use of high flow nasal cannula is post extubation in a bigger babies. High flow nasal cannula is an invaluable tool in supporting a pediatric patient. Also, adequate flow is important, most effective in infant, and always consider when escalating care for respiratory distress failure. There's a gap. Is there a role of high flow for the extremely low birth weight babies? We already said that as a primary support, no, but if you have a post extubation, you can try with a great caution. Hunter trial role of high flow in non-tertiary settings. So let's say you are not working in a tertiary setting, then what will you think? So these are the results of the Hunter trials. So the nasal high flow therapy was not shown to be non-inferior CPAP with a higher incidence of treatment failure than the CPAP and used in non-tertiary special care. But the thing is that they include those babies because the non-tertiary centers in those countries, and the high-income countries, means that you have babies more than 31 weeks of gestation. So these are the bigger babies. So that's we said that in a bigger babies, you can try, and the chances to failure of the treatment is less as compared to the smaller babies. So yes, you can try in your non-tertiary care setting in a bigger babies. In one version of high flow better than the others, we don't know. Can we safely go higher with the flow rates 8 per liter and above? Still is a controversial, and there are many studies going on into that. So again, CPAP is the gold standard if you really want to use it. So if is there any question? If not, then I will continue. So now go to the
sorry for interrupting. Let's take questions and then we continue onward because participants are
Sure. Yeah, that's why I'm asking that if any questions, this is better if you ask me, so you know. Yeah, okay. Go ahead. Yeah, Vikram, go ahead.
My name is Dr. Junaid Khan, and I want to ask a question. Is there any study which shows there is a difference between hypomedical and CPAP causing the pneumothorax. Which one is good regarding seeing the condition of pneumothorax? Which is good? CPAP, we should prefer CPAP or hypomedical?
Yeah, can you repeat the question? So I understand what is the thing. So this is the answer. As you can see, the high flow group, okay, and the CPAP group, okay. There is no statistical difference at that time, you know, but it depends the CPAP. If you are using a CPAP of a very high PEEP, which is 8 and above, then yes, the pneumothorax is high, but otherwise at any time, there is no statistical difference. I hope I answered the question, Vikram.
Yes, yes, sir. And there is another question, please.
Sure, go ahead.
Can we continue CPAP or high level flow oxygen? The patients of the pneumothorax is still.
Vikram, can you repeat the question?
Yes.
Can we continue the CPAP and the patients of the pneumothorax?
The question is that if any patients on CPAP or high flow, if developing pneumothorax, so we should continue that support or we should do something other?
No, if the baby is stable and develop pneumothorax, pneumothorax is not a contraindication for the CPAP. You continue with the CPAP, okay? If the baby is not stable, retaining the PCO2 and this thing, then do not put on high flow. You have to intubate the baby, okay? Until the initial insult resolves. So the CPAP itself is not a contraindication for pneumothorax itself is not a contraindication for CPAP. So if some, because most of the time it resolves very quickly and it will not help. It will not harm the baby. I hope I answered the question.
Yes, there is another question.
Sure. Go ahead. Again, I cannot hear.
थोड़ा जोर से बोलो.
You repeat, Vikram.
Yes.
Patients of the congenital heart disease who are the respiratory distress, can we get the CPAP?
The question is that if any patient diagnosed as a congenital heart disease having respiratory distress, so we should consider bubble CPAP in that cases?
Why not? Yeah, you can. You can consider, you know, the problem is that if the congenital heart disease, how much oxygenation you want to keep. Okay, so for us, if let's say if the baby of TGA, we accept 70% 75 and above is fine, and if it is the real distress, we use the CPAP or high flow nasal cannula. So most of the time if the baby not apneic because of the prostrin, we don't intubate the patients and we continue with either of those two.
I want to ask a question that I'm very aware that the FI2 that is delivered through the high flow is not as accurate as the FI2 delivered through the CPAP. Is that true?
Vikram, can you help me?
Is there any difference of FI2 delivery with a nasal CPAP and a high flow? Accuracy of FI2 Provian at alveolar level?
It is a very technical question. So the first thing is that the CPAP, you and I'm talking when you have the blender, okay? So please, so if you have a blender and you put the baby is on 40, let's say 40% oxygen, okay? We are considering in both techniques that all 40% of oxygen is going to the baby, okay? We are not considering like a pressure in both things that it is not going to the baby. So oxygenation is actually independent of these two modalities. Whatever the amount you put, you consider that, let's say you put on 50%, it means that the baby getting the 50%. This is one thing, but technically if you ask, of course it is dependent on pressure, it is dependent how much pharyngeal pressure, how much the distending initial pressure. But for us to make it very simple, whatever the amount of oxygen you put, consider the baby is getting it. Okay, don't go into the technicalities, because then you will end up giving more oxygen. Okay, so make your protocol, make your guidelines according to that, that whatever the amount you put it on the blender or your regulator, this is the amount the baby is getting. Okay, so because we don't want to give too much oxygen of that, but of course it depends on many other physiological parameters. It's not is the same. So what is the tenting of the pharynx at that point of a time, at how much flow, how much is the pharyngeal pressure, the mouth is closed or mouth is not closed. So it is really a lot of technical issues, but because of the safety of baby, we don't want to give too much oxygen. We consider whatever we are putting in the oxygen, they are getting the baby. I hope
You got your answer?
Clarify this question.
Yes. Yes, sir. There is another question.
Sure, go ahead.
Valid or jointly or from what are the absolute contraindications?
What are the absolute contraindications for the nasal CPAP other than cleft lip, microgenthia, cleft palate, and apnea, diaphragmatic hernia? Is there any other absolute contraindication for CPAP?
No, there is no absolute contraindication. The absolute contraindication is only, to me, is these which you already mentioned. The diaphragmatic hernia, if you know antenatally, of course you have to intubate the baby. And of course, if the baby is apneic, okay, you you cannot do much, because whatever the pressure you give, it will not reach to the baby. So these are the 2-3 contraindication. You avoid CPAP and go directly for intubation.
There is same question. Can we can we use CPAP in babies with TGA or duct dependent lesion? I think we can use if there is no any respiratory failure.
I don't know why this question is arising, because TGA is a congenital heart defect. Okay, so if you know that how much oxygenation you want in this baby, and we want not more than 75% saturation in those babies, or 75 and above. So if the baby is maintaining it on the CPAP, then it's well and good. As I told, I'm repeating myself, we only intubate if very high dose of prostaglandin is needed and the baby is become apneic again and again. That's the only reason we are intubating those babies. So we continue either with a high flow nasal cannula or this thing. And if the baby is comfortable, not tachypneic, and maintaining the saturation 75, 76, 78, we don't give any support, because this is not the pathology in the baby respiratory. The pathology is the cardiac. Okay, so that's make sure that these modalities, these two, can work in any congenital heart disease, because we do not need to have a very high oxygen saturation in those babies. Okay, so unless and until the prostaglandin affecting your baby life, then continue with that. Vikram, you have to help me. Yeah,
if a baby is prolonged non-invasive respiratory support, so how we should ensure that there is no significant abdominal distension or CPAP belly, as we already discussed.
So this is the thing, that of course when the baby on these type of support, you have to have the NG tube. Okay, and of course you have to examine at least, I don't want you to examine the baby if the baby is stable, or too much frequent time, but of course once in a day you have to examine the baby and see if there's any abdominal distension or anything else. Your nurses should know how to deal with the CPAP belly. So it's very, easy. that you can deal with that. And if you think that is a CPAP belly, then do an X-ray and see, and try to remove the air through the NG tube. So as you can see here in this picture, the NG tube is there, the very well fitted nasal cannula, and look at this, there is no CPAP belly in this baby. So most of the time, this is the nursing care, okay? Just go through it and teach your nurses that how to see with this CPAP belly. It will be really very good. The other thing what you can do, if you need a little bit, put the baby after the feeding or after the thing in the prone position. Of course, the baby is on monitor, so you don't have to worry about the sudden infant or something like that. But the baby is in the unit. The prone position is help the baby in maintaining the saturation and also decreasing the CPAP belly. The prone position from the neonatology is taken by the COVID into the patient, and most of the COVID patients we are putting on prone position. It helps in maintaining the functional residual capacity. Again, I don't want to go through into the physiology, but this is another way you can decrease the reflex and you can decrease the CPAP belly and the saturation that the baby can maintain.
Right. Any other question? So I think we can move forward to
Sure.
our.
So again, as we are discussing that this is the best thing that we have the CPAP, and again, it's the gold standard. But Vikram is after me, so I have to talk about now the NIPPV. Now, what is the NIPPV? Is the non-invasive positive pressure ventilation. These are the many other names, okay? Cycling, CPAP with the backup rate, nasal ventilation, nasal SIMV, nasal IMV, but the unifying name is NIPPV, and it is not the same as a BiPAP or BiPAP. Why NIPP? Because there is a lot of failure. So 30% of low birth weight infant, I'm talking about now the very small babies, and very low birth weight infant failure on the CPAP is about 50%. So the optimal CPAP, more than 5 centimeters, short binasal prong, and the caffeine. If it is failed, then you have to have other modalities before you go to the ventilation. So the non-invasive ventilation, we call it non-invasive ventilation. It is the same parameters we have to select as the invasive ventilator. So how does it NIPP work? The simple answer, I asked this question to many of our senior colleagues, and which we call the respiratory physiologists, but they said, we don't know. But anyway, there are some theories about it. First, it induces the head paradoxical reflex because it gives you the sigh when you need it, when the body senses that your oxygenation is going down, it gives a breath with the higher pressures in it. So this is called the head's paradoxical reflex, which we said in the early presentation. It increased the mean airway pressure, same as the ventilation, increase the tidal volume, pharyngeal dilatation, and improve respiratory drive. Short-term effects is reduce the arterial PCO2 and increase the saturation and improve thoracoabdominal synchrony. So the main thing is that it is working exactly the same as we compare to the to the ventilation. So look at this synchronization is very important in all those modalities. If you give by the CPAP, it is not synchronized, but if you give the NIPPV, it's very much synchronized. The abdominal is the red and the chest wall is the green, as you can see in this thing. So this is one of the way the NIPPV is doing a little bit better than the CPAP. The physiological principle is the same. From the adult, the NIP produce vocal adduction and glottal narrowing, and data suggests that the high peak pressure does not consistently increase the likelihood of the chest inflation. So this is the one of the way to understand it. Okay, so this is the heart rate, this is the respiration, and this is the oxygen curve. So let's say this is the heart rate and then the respiration, and the baby get apneic, as you can see here. The heart rate start falling because of this apnea, and then when the baby start breathing, then the heart rate goes up. But look at the saturation curve. As soon as the baby get apneic, the saturation goes way below. And this is clinical apnea phase on the nasal CPAP. Okay, but look at the bridging the apnea through the NIPPV. The heart rate, the baby is on NIPPV, and then during the apneic time, again, the baby has the support as compared to the CPAP because of you set the higher PIP and the what you call the PEEP also, and as you can see, the baby is breathing. So the oxygenation curve is not go, of course it goes a little bit down and then come up. So it can bridge the apnea between the, if you compare the CPAP to the NIPPV, because of the PIP which is setting up in this machine.
So Dr. Junaid, I have a question.
Sure.
So I know the NIPPV bridges the apnea because of the sigh breath we put on. So what about the biphasic CPAP? So when we give through the vices, biphasic CPAP with some rate on, with the eye time. So will it work the same?
Yeah, so I will show you, this is the next slide, which is, okay. So what is the BiPAP, okay? And what is the NIPP and what is the difference, okay? So traditionally, the NIPPV, you have to have a infant flow drive, but mostly the ventilator. BiPAP level, you can buy the flow drive, or some machines are doing this. The principle is mimic timings and setting using during the endotracheal ventilation. So the NIPPV is same or mimic the invasive ventilation. Here, independent breathing, sorry about my square is a little bit down, on 2 PEEP levels. That's the main difference in it. The NIPPV is the peak inspiratory pressure and the PEEP, okay, same as a ventilator. But the BiPAP level is the 2 PEEP, which is the, let's say 5, and then on a higher PEEP, which is the 10. So the sigh breath, okay, is only delivered in this condition. What is the question of Dr. Shabina is not that effective as compared to the NIPPV, if you can see that, because this is the 2 PEEP level. It is not the 2 pressure levels, PIP and the PEEP. This is only the 2 PEEP pressure which is going on. So as you can see here, the peak and PEEP pressure is more than 5 centimeter differences. Here it is less than 4 centimeters. So sometimes it is 9 and 5. So it is that's the maximum you can put it on BiPAP level. So the support of that apnea by the BiPAP level is not as effective as to the peak level. Then high pressure deliveries is the variable is 10 to 60 per minute. Here is only 10 to 30 per minute. Okay. The high pressure duration is 0.5 second, and there is a long is 0.5 to 1 second. So this is the main difference, that the amount of the sigh breath or the peak inspiratory pressure you can only be provided by the NIPPV as compared to the BiPAP. So that's why the BiPAP is a little bit inferior to the NIPPV as when we come to the apnea. So again, if I'm not explaining to you very well, try to think about it. If you have a 2 PEEP pressure, one is the lower and one is the higher. So it will affect only the positive and expiratory pressure. Instead, if you have a peak inspiratory pressure and the PEEP, okay, so it can give you more effective breath, and the pressure difference is higher in the NIPPV as compared to the bi-level CPAP. So that's why this is the difference, and that how we can deliver the sigh breath. I hope, Shabina, I answered your question.
This is Huma, and yeah, well answered.
Huma,
Thank you.
yeah,
Thank
Huma,
you.
sorry.
Thank
Yeah.
you.
So now the NIPP on CPAP for preterm infant, there is a lot of meta-analysis, about 1,000 babies. And according to this study, there is no significant reduction in the chronic lung death, but there is a significant reduction in the incidence of respiratory failure and need for intubation with the NIPPV. So this is the work done by the Dr. Kirpalani. He include all the studies, and they found some benefits in the some of those studies, but there are few studies which show no benefit. But the Professor Ramanathan just published in 2019 the what he did a very interesting study. Okay, he first of all is a huge study with the 10 years. Then he took, including his studies, he took all the studies, okay, and see how much CPAP failure. So red, red is the CPAP and NIPPV is the green. So look at this. In all the studies, the CPAP failure rate in a very small babies, we are talking about less than 28 weeks, is higher as compared to the NIPPV, and it is statistically significant. Not only that, there's in JAMA in 2017 also published this thing. Now, I told many of our junior colleagues that they should know how to read the meta-analysis. Okay, please be careful. So what they found it out that whether you have a synchronized NIPPV or non-synchronized, it still give you a good results. To read those meta-analysis, please try to learn, look at the heterogeneity of the study, which is the I-square, and it has to be less than 30%. Otherwise, the meta-analysis is not that conclusive. Okay. There's another thing in post-extubation, again, it favors the NIPPV in a very small babies as compared to the CPAP. Failure to post-extubation, going very quickly, all those in favor of NIPP except BPD, there is no difference. If you favor the NIP or favor the CPAP, there is no difference in the rate of the BPD. So NIPPV give you a good results initially. So the baby will not go to intubation, baby will not get the failure rate as compared to the CPAP. But the long term, the BPD is not that much difference. Pneumothorax, of course, if you are using the high CPAP pressure, then of course you are giving the more pneumothorax in the CPAP as compared to the NIPPV. So these are the all the.
Sorry. So another question: in all those studies, was there any cutoff gestational age where they preferred NIPPV versus CPAP?
As I said, it's a 28 weeks and below.
Okay. Okay. Thank you.
Okay. So the final outcome, this is one of the things from the India published in 2021, that NIPP was significantly better than the BPD outcome, and they have, but I don't know the full thing, but anyway, they showed a little bit better. Now, so the question arises that in these small babies, when the failure rate is high of the CPAP, then why don't we start the NIPPV in the delivery room? There are some centers doing it, but still there is no data that if we use the NIPPV in the delivery room is better. So the most of those centers, including our center, we bring the baby, smallest baby on the CPAP, bring the baby to NICU and start on NIPPV if we have to. Come to the settings. This is the similar, very simple way. Okay, so again, the baseline CPAP, which is 5, we put most of the time, or sometimes 6. Then PIP 20, and depend upon how sick is the baby, you can increase up to 25. Duration of the high pressure inspiratory time, 4 to 5 time constant, so which is 0.5 second inspiratory time, and the flow rate, which is about the respiratory rate, which is about 40. So this is the NIPPV protocol. It is published in the Neo review. Whether you accept that or whether you develop yours, but this is the usually generalized guidelines. So the rate, you will start with 40, a PIP of 2 to 4, more than a PIP on manual PPV, which is like 25, 24. Positive end pressure, as I said, 5 to 6 or 4 to 6, they said, but of course, it is 5 to 6. And the time inspiratory is 0.4 to 0.45, maximum is 0.5, and the flow rate, it has to be 8 to 10 liters per minute. In extubation is the same, as you can see, that the frequency should be 50 to 25, then 16 PIP 5, and we start with the lower setting when we extubate to NIPPV. Vineet Bhandari from USA and Vikram Aditya is also mentioned about the troubleshooters, that if you have hypoxemia, then what you will do, hypercarbia, then what you will do, if you have both, what you will do, and if you have apnea, then what you can do initially to avoid the intubation as much as possible. So these are these few parameters you can look into it. Now, reintubation criteria is very simple. If the pH is 7.25 and the PCO2 arterial is more than, if you all remember, PA means arterial, if more than 60 mmHg. So the frequent 2 to 3 episodes per hour apnea bradycardia, not responding to caffeine therapy and the other therapies, or frequent desaturation 3 episodes per hour, not responding to increase your NIPPV setting, then of course you don't have any choice but to intubate. How to wean from that? When FiO2 is less than 40%, PCO2 less than 60, and pH is more than 7.25, then start weaning the PIP and then the PEEP. And of the NIPP, when PIP is 15, PEEP is 5, rate is 20, and FiO2 is 30%, whatever it comes first. So it means that the baby is breathing on its own. And most of the time, we put the baby, because these are the smaller babies we are talking about. So we off the NIPPV, and we put the baby on nasal CPAP unless and until the growth, the postmenstrual age is more than 30-31 weeks of lung growth.
So why not directly wean to room air from NIPPV instead going to the CPAP?
This is the reason. CPAP until 30 weeks, but to promote the lung growth. Okay.
Okay.
So I told you initially also that the CPAP is not only providing the PEEP, but it helps in developing the lungs. So if the baby is small, let's say the 26-weeker US NIPPV, and now the baby is doing fine. So it's better to put the baby on CPAP as compared to the high flow, this thing, because it helps in the lung growth, and continue the CPAP, although it is in the room air up to 30-31 weeks of postmenstrual age. So
Okay,
these are the, yeah, sure.
Okay. No, it's okay. It's just like question for question. So like when the CPAP so when the CPAP is for the lung, when the CPAP is for the lung growth also, then why not CPAP to begin with then?
Okay, so that's the point. Homa, I have to repeat this whole presentation. Why not CPAP before? Because in the smaller babies, the failure rate of CPAP is much higher. You got my point? I showed you the picture of caffeine.
I know, but like I don't know, like there may be more evidence needed, because CPAP is like we have to see the inflammatory markers also in inequality lactases also. So
yeah,
I don't know.
Now this is the enough evidence that the CPAP failure in babies less than 27 weeks is higher. Okay, so to avoid, because once the CPAP fail, and then you have most of the people go back to the intubation, which is more injurious.
Yeah.
So they said that start with NIPPV and then continue with the CPAP for 30-31 weeks. We did a lot of this practice, and in addition to this, what we are doing is that if the baby less than 26 weeks, we give the surfactant. I will show you in a minute. With the mist technique, and then we continue with the
in our unit, like I'm working in Edmonton, so in our unit we usually extubate on NIMV, like less than 28 weekers. And we do gradually decrease the pressure as like your criteria is the same. And then we directly go to room air from the NIPPV instead of changing to CPAP. So that's why I was thinking, okay, fine.
Yeah.
Okay,
So
no
that's the reason it is. So this is the same. Now, last but not the least, I will go through very quickly because still there are a lot of studies going on with the nasal high frequency ventilation. Yes, the main thing is to decrease the PaC2 in those things. So it helps in term and preterm. And if you have with the non-invasive ventilation, if you have only the problem of PCO2, then of course you can try, but still it is a very early stages of this nasal high frequency oscillator ventilators. So the primary nasal high frequency versus CPAP infant with RDS after CureSurf, as you can see, the need for invasive ventilation is decreased. Okay, so the same concept which I give you, the NIPPV, if you continue with the CPAP, the chances of failure is higher even after the CureSurf, or I don't have to take the name of CureSurf, but anyway, whatever the surfactant you are using as compared to the nasal high frequency. So this is the one of the way you can look into it, but it's still they are the large randomized controlled trial more needed other than that. So again, the settings it different in different ventilators or different equipment. So for example, if you have a Draeger, which we using a lot, but we are not using the nasal high frequency. But let's say if you have this thing, this is the slides from Professor Ramanathan. Frequency should be 6 to 10. Then amplitude is about 2 times the mean airway pressure. The I ratio is 1:1, and similar to the IMV or CPAP, the whatever the mean airway pressure. So this is the settings they are putting into it, but we are still not using it because the evidence is still coming up more in about the nasal high frequency. Weaning from high frequency is the same if the PCO2 is less than 50 and pH is more than 7.25, then decrease amplitude is stepwise and then come out to the or continue with the CPAP. So the detail and to be concerned, does the type of ventilator have an impact? So we don't know, or probably yes. So what equipment you have, how it works, is still need to clarify. Does the type of CPAP generator have an impact on nasal high frequency? Yes. Does the type of nasal interface have an impact on nasal high frequency? Yes. Is oxygenation improved? In animal studies and observational study, yes, but most of the human studies showing the effect on the PCO2. So that's why still we are looking into other evidences. Is nasal high flow ventilation safe? Yes, no adverse event reported so far. So with the conclusion with this, it works in the nature. You saw the dog painting, so it works in the nature. It should work in the clinical setting, and NHFE is an easy applicable. Yes, the very effective in carbon dioxide elimination, has the potential to reduce the lung injury. In premature lamb model, there are a few studies from the Switzerland by the Peter Remensburg, yes, but not very evident. High frequency nasal ventilation is nasal CPAP plus, not high frequency oscillator minus. We don't know. If a nasal CPAP is well established in a center, then an HFO is a worth to be tried out. So if you are very comfortable with the CPAP, you are fully trained and you know the CPAP and it is working, then if you have a problem with the PCO2, so before you go to intubation, you can try the nasal high frequency oscillator ventilation. So this is the evidence of what Dr. Huma or Dr. Shabina is asking, that this is the CPAP, the bars showing the studies in comparison to it. So CPAP, there's a 6 meta-analysis with the high frequency nasal cannula. CPAP versus variable flow CPAP is only 3. the CPAP versus NIPPV is 5 meta-analysis, and so on and so forth. So if you ask the Professor Ram, the hierarchy of those non-invasive ventilation, so he conclude that synchronized NIPPV is the best, then NIPPV is the next, then the nasal high frequency, then the CPAP, then the high flow, then the BiPAP, and then the high flow nasal cannula. So this is the way he did this meta-analysis according to these limited studies comparing to each other. So my response, NIPPV may offer advantages. Synchronization is better. If you don't have, you can use it with that. So now, NIPPV does not appear to be associated with increased side effects. So this is the response. So now, summarize the whole this thing. Let's say you have a low-risk infants, 1.5 kilogram, more than 32 weeks. Mother get the antenatal steroid, no chorioamnitis. So anyone, Vikram, what modality you start in this baby?
So we usually start with the high flow.
Excellent. So high flow or the CPAP, whatever you feel comfortable. Now next scenario, moderate risk, 1 to 1.5 kilogram, 28 to 32 weeks. Steroids are given. More than 32 weeks, 1.5 kilogram with severe distress. So these are two scenarios in one. One is the baby is 1 to 1.5 kilogram. One is 32 weeker and above, 1.5 kilogram, but severe distress. So what you will do with this baby?
In such situation, we start with the high flow and decide for the surfactant. If it's still baby having higher requirement, then we can consider for CPAP, SNIPPV, and if baby need of the intubation, then we can consider intubation. But primary support we offer there is the high flow.
Okay, so here in both scenarios, we started with the CPAP in the delivery room, continue CPAP in NICU, continue with the caffeine and early rescue surfactant, as Vikram you told. We don't use in moderate risk, especially in this one, the high flow nasal cannula, as I showed you, the evidence are not supporting it. Okay, so we continue with that. Now, high risk is easy. You have to start with the DR CPAP and then initiation of NIPPV or CPAP depends with the caffeine, antibiotic as needed, and early rescue surfactant. Of course, you have to monitor all those things and the supportive care, nasal trauma, nutrition, and all those things. Appropriate escalation of support if failing on the initial mode. So, if the baby is small, if the baby is in distress, if there is no steroid plus chorioamnitis, and you increase the risk factors in the babies, then we go up to the NIPPV, but in the DR, we start with the CPAP. And of course, the caffeine and give early rescue surfactant by the MIST technique. So the overall, to me, a nasal CPAP is a gold standard. High flow is non-inferior if it is secondary use and not as a primary use in baby less than 28 weeks. Rates of CPAP failure remain high among neonates, so that's why we have to have some backup before we go to the ventilation, which is the NIPPV. Data from randomized control trial shows that 45 to 50% of high-risk babies fail CPAP within first week of the life. So that's the reason that we use NIPPV in those small babies. Early higher FiO2 correlates with the CPAP failure. So it depends what is your thing. The consensus guideline of 2019 European say 30%. The Canadian Pediatric Association, they go up to 50%. It is just published in 2022. Maybe Huma knows he's working.
Yeah, for older neonates, yes, like older gestational age, but for less than 28 is still 30%.
30%. So this is something, and most of us in US and US based units is about 30 to 40%. We are considered as the CPAP failure. Early radiological evidence of severe RD is a strong predictor of CPAP failure. So now another modality we used is the lung ultrasound to see the severity of the RDS, and we have a very well trained staff who can do the lung ultrasound. Use of early NIPPV may help. Compared with insured, the LISA or the MIST are better. So if you want to develop one skill, I must recommend that develop the skill to give the MIST, which is the minimal invasive surfactant therapy. LISA has some problem because you have to use the Magel forceps with that. It has to go through that. But anyway, whatever you feel easy, try to develop that skill. Recommended use of bubble CPAP over variable flow CPAP. We discussed that. Early caffeine therapy, we started at day 1. And we continue with, again, in academic neonatology group, there's a discussion about the dosage. We don't give too much caffeine. We don't give for too long period. Please, the caffeine is the medicine. There's a lot of paper published that if you overuse it, it will affect the neurodevelopmental outcome. So we use up to 34 weeks maximum, okay? We use up to the maximum dose, the maintenance dose is 10 milligram per kg maximum. We started with 5 and then titrate accordingly. The effectiveness of non-invasive ventilation again and again and again and again can be augmented by having a proper protocol, your practice, your skill, weaning, skin care, positioning, our nurses help, and care during their application. Thanks a lot, and I hope I give a little bit of message about non-invasive ventilation.
Thank you, Dr. Junaid. It's a well-presented session.
Yes, Vikram, if you have any question. Vikram, are you there? Or
Dr. Junaid, can I just add one comment?
Yeah.
Excellent presentation. I really enjoyed always listening to you. I think from a Pakistani perspective, because I've been in Pakistan now for nearly 2 years now, and I think for us, we need to focus on basically just 2 modalities, considering the local logistics, which is one is, as you mentioned, gold standard CPAP, and the other one is high flow nasal cannula oxygen.
Yes, of
I think
course.
that's my experience so far, that if we get better at these 2 modalities, then our non-invasive respiratory support for our preterm babies probably will improve. You're very right that NIPPV and frequency is superior, but I think given the local logistics and local population, if our units can get better
Yes,
at just these
Dr.
2
Junaid, I'm
basics.
here. Participant wanted to ask some question.
Sure. Go ahead. Is Yasser asking? Yeah, Yasser, I'm 100% agree with you. And but because of some this thing to knowledge, the Vikram asked me to cover this thing. Of course.
No, I think that's. I think we obviously have to know what is going on in the developed NHUs as well. But I think just for our own, practically, I think we have to get better and better at using standard CPAP.
Walaikum assalam.
Thank you.
Sir, thank you for the wonderful presentation. We have a question for you. You mentioned that the prolonged use of caffeine can affect the neurodevelopmental growth.
Yeah.
So we are keen to know that for how long is it safe to give caffeine, and till what gestational age if you're giving it to the preterm baby? Could you just put light on that?
So you asked me the question. Can I ask you a question? Why you are giving caffeine?
To avoid apnea and to keep to avoid apnea, actually to stimulate the breathing.
Yeah, stimulate the breathing. And up till what age you think that that is developed? Maximum 34, 35 weeks, okay? After that, the effect of the caffeine is not that there, because the reflex of having the control of breathing is improved. So that's why you remember that by 34 weeks, we start the oral feeds, and it has to be fully oral feed, because the suck and swallow reflex with the control of the breathing is fully developed. So that's why 34 weeks, maximum 35 weeks, we give this caffeine. After that, we stop it and then we wait for 7 days, 5 to 7 days, because the half-life of the caffeine is very long, prolonged until we discharge the baby. So the prolonged use of the caffeine is not advisable, as I told you, because of the neurodevelopmental index is in those babies. Just published by Dr. Ben Clary just a few months ago. It's not that great. So be careful with those things. This is similar effect. You know that neonatal steroids, antenatal steroid is, everybody is so much excited, but do not give beyond 37 weeks of pregnancy, okay? Because then the outcome and the neurodevelopmental outcome of that steroids are also not favorable. So similar, that any medicine you use, but the overuse it, we should avoid. I hope I answered.
Thank you so much. Yes, thank you so much. It's pretty clear. Thank you.
बिल्कुल नींद आ रही है चाय भी पिए फिर भी नींद आ रही है दोनों की हाँ
Sir, Assalamu alaikum. I'm Dr. Haresh Kumar. Sir, my question is that regarding the CPAP, as you say, the continuous CPAP for 30 weeks of the gestation for the brain lung growth. So if baby not develop any respiratory distress or any apnea and recovered and maintaining oxygen circulation, so still we continue the CPAP for 30 weeks gestation.
So what you will do? Let's say that the baby is doing very fine, as you said. So what you are practicing, what you are doing now?
If baby is maintaining oxygen saturation and on feed on demand, we here keep the baby without the oxygen and shift to the mother on feeding.
30 weeker.
So if
29 weeker. So this is the thing, that's the difference in this thing. See, the situation in Pakistan is different. Of course, the bed and all those things, but we don't recommend to the smaller babies. The chances of mortality is very high. Not in those couple of days, but the later on, those babies have a higher mortality as compared to the other babies. Secondly, the 29, 30 weeker, if the baby is doing fine, then who will feed the baby? Because the baby is still on NG feeding, am I right?
Okay, sir. Yes, sir.
So that's why we have to wait until the fully developed, at least 34, 32 weeks of life. Now, the thing is that I know the situation in Pakistan is very different and is happening, and many, they discharge the babies on NG feeds, and in Indus hospital, they show me the follow-up and they showed me many babies. So for that, we have to have a very committed mothers. But as a standard, we cannot recommend that practice.
Okay, I mean, standard is that we continue for 34 weeks.
Yeah, to continue 31, 32 weeks, and then you
30 weeks. Yes, yes, yes.
Yeah.
Okay, sir. Thank you, sir. Thank you.
One by one.
Anyone?
Yes.
Anyone ask the question, please?
If anybody have to ask a question, raise your hand.
चलें सर, थैंक यू वेरी मच. मेरे ख्याल में सबको भूख लगी है, थोड़ा बहुत इनको हैंड्स ऑन भी कराएंगे. और
चलो, थैंक यू वेरी मच.
I just want to know for till how long this conference will be going on. Like, what is the time?
There are still 3 more topics, just like supportive management in neonates on respiratory support, and conventional mechanical ventilation in neonates, and high frequency oscillatory ventilation in neonates. So 3 talks, and it will take almost around 3 hours.
Okay, then goodbye from me, because it's 2:43 a.m. here in Canada.
Oh.
I'm going to sleep now.
Okay.
It was so interesting. That's why I keep. So thank you for this nice conference. Thank you.
Thank
and
you.
goodbye. Thank you. Bye.
Thank you
Thank
very much, Dr.
Thank you.
Thank you.
Allah Hafiz.
Allah Hafiz.
So, thank you for paying partial attention. कुछ तो सो रहे थे, कुछ मोबाइल देख रहे थे, कुछ बीच बीच में जो है थोड़ा कंसंट्रेट कर रहे थे, लेकिन जाहिर सी बात है अटेंशन मेंटेन करना अपना जो है वो मुश्किल होता है, और एक लॉन्ग बिल्कुल मैं समझ सकता हूँ एक कंसंट्रेटेड एक्टिविटी है जिसमें आपको सिर्फ 15 मिनट का गैप मिला था चाय का, अभी भी इंशाल्लाह आपको एक मिनट इसको थोड़ा तो ये कि
like सेट स्पैन ना अगर बुखार ना उतरे तो देंगे वो ठीक है अभी ना इकरा को दूध सिर्फ 2 दफा दिया करें वरिशा वसीहा 2 दफा दूध दिया करें माँ का ऊपर का दूध बिल्कुल मत दें बिस्किट रस केक बेकरी नहीं दें पानी उबाल कर दें साबुन से हाथ धो कर पिलाएं ठीक है ये दवाइयां लिखी हैं दें इंशाल्लाह अल्लाह करम करेगा नहीं मोहम्मद हसन क्या हो गया इनको?
डॉक्टर इसको ना मोशन वैसे ये जो आपके सामने ये ट्रीटमेंट है ना, ये तकरीबन इसका ना वो 15-20 दिन गला बहुत खराब रहा है, बारीक खाने से कि चमकदार वो ट्रीटमेंट होता रहा इसका यूनिवर्सल तकरीबन 15-20 दिन ना। अच्छा अब जो है तकरीबन उल्टी है आपको हम इमरजेंसी में ना आपके इमरजेंसी में ना तो लड़कों ने लगा दिया और एक सीरियस किया था उससे ना इसको आया बोला मुझे
तो फिर इसमें टेम्परेचर जैसे आपने एक एंड जो है आप बोतल की तरफ डायरेक्ट कर देते हैं इसमें भी इसी तरह से आपने दूसरा एंड जो है आपने बोतल की तरफ डायरेक्ट कर दिया तो उस पे उसकी पीक करेंगे। ये हमारा हो गया और हीटेड ह्यूमिडिफाइड दिस इज वेरी आपको कोई इंट्यूबेशन की नीड नहीं है, तो वेरी चीजें हैं और इवन बच्चा कोई ज्यादा परेशानी की बात नहीं है। बच्चे अमूमन बहुत सही रहते हैं, कंफर्टेबल रहते हैं, आपकी एफर्ट भी कम हो जाती है, एक्सपेंसेस भी कम हो जाते हैं और इंटेंसिटी ऑफ मैनेजमेंट भी कम हो जाती है, रिस्पांसिबिलिटी
अब 1 घंटे 2 घंटे जो आपके हमेशा तो चाहिए रात से ही मोशन उठी
और भी
फाइल ओपन हो गई है सर, यहाँ से डिस्क्लोज करेंगे
ब्लेंडर और मेमोरी
ऐसे जाते हैं लेकिन फिर रात को हमें लेके आना पड़ता है फिर
ना
मीठी डॉक्टर कितने दिन होता है?
3 हफ्ते। है दी खराब इसमें ठंडा पानी जूस बोतल पापड़ फुले गोलियां टॉफियां नहीं देनी ये दवाई देना पे सुन देनी है खैर
सब क्या से रहने का बड़े सीक्रेट चुप पड़े अब सवेरे ने 3 दिन गाले मैं तो बड़े ऊपर छुपके जाया करना तरीके से तकलीफ तो नहीं सब
इसमें दवाई दे एक हफ्ता
ये इनमें नबील की 7 ठीक है
जी बताइए क्या हो गया इनको?
बताइए क्या हो गया?
चक्कर आते हैं और मछली होती है पेट में भी दर्द होती है, पेट में दर्द कहते हैं।
बैठे आप लोग बैठिए। पेट में दर्द होता है, वर्टाइगो चक्कर आते हैं, मतली होती है, नौजिया है, भूख कैसी,
भूख कम होती है,
छोटे पेशाब का रंग
कब से इसकी कैफियत है?
3-4 माह हो गए।
मुंह खुलाकर
बड़ा पेशाब कैसे करता है? ब्लड टेस्ट लिखा ही करवाइए इसका। हाँ जी,
क्या नाम है बच्चे का? शकीला यूनिट 15 माह 5 किलो बैठ 15 माह में बैठ 5 किलो 5 किलो ये हो गया इसमें मसला बहुत ज्यादा है ये देखो खान पीने
दूध केड़ा दल जाओ रंग नीला कर दी
नहीं 100 सर अच्छा छाती देकर एक्सरे करवा दिया काउंटर दवा लगा जोहान जी जी कितनी उम्र है 3 माह जोहान 3 माह 5.25 किलो 5.25 किलो
जी बताइए क्या हो गया इनको?
जैसे जबड़ा वो नहीं है ऐसे है बिल्कुल ये सांस ले रहा है जैसे
ये कब से सांस पैदाइश से ऐसी है?
हाँ ऐसी है
नहीं होना करना नहीं करना। अच्छा दूध क्या देते हैं?
जी दूध पहले तो देते एफएमटी देते थे अब जो है ना इसको वो गाय के दूध दिया गाय के दूध से पहले का इसको है आवाज बहुत ज्यादा सीनियर की देता है
सुनना तो वही है कतला
जी हो गई और मैं ये जो खाना है ना बड़ा उसके साथ पानी भी करता है ये ना छाती का स्पेस करवा ले काउंटर में वो बता दूंगा
लास्ट में जो था इसका ना 1.5 था एचजीबी 208 है लास्ट वन इसका 2284 था एपोमस जारी रखेंगे सिल्बिया एस्पाइट भी एक सिर्फ ओमी में प्लिक है अभी इसका परहेज 1-2 हफ्ते जारी रखिएगा इंशाल्लाह और इसमें पीडियाश्योर पाउडर
और इसकी कोई हाइट तो कोई
वो पीडियाश्योर से बेहतर होनी चाहिए
सही और इसमें ये तो निकला था वो लाकड़ा काटा, तो उसके बाद में ये तो दाने निकलने शुरू हो गए हैं। ये
फेशियल बी क्रीम सुबह शाम लगाएंगे, ये मिल जाएगा।
एक तो नंबर लेके देंदा था ये जुम्मे वाले दिन ना सरगो देव
दिल का अल्ट्रासाउंड करवाएंगे इसका।
डॉक्टर फजल साहब अस्पताल में डॉक्टर साहब आप कर दें सरगो था जुम्मा नंबर ले कितना बाल नंबर ले ले सुनो बोलो जुम्मे दिन एको करवा के डॉक्टर जरूर करना
दिल का अल्ट्रासाउंड जरूर करवाओ, ग़िज़ा अच्छी करो।
सर ये बहुत स्लो चल रहा है वैसे। सर ये उनकी हुसैन साहब की ले ली ना, ले ली। पॉइंट आपके पास ही है जो पड़ा है। ये देखिए ये पार्ट तो एक पे ये पड़ा हुआ है जो इधर लगा हुआ था। अरे यार अच्छा ठीक है इसमें लगा दूं।